This is colloid, and as a medical student, you will call it as, you will not say colloid, you will say thyroglobulin. Very nice. So this is thyroglobulin, right? It is present in the follicle. So follicles are of variable sizes. It depends how much activity you need. So it starts working like that. In a high power, you can see it is lined by cuboidal to flat epithelium, depends. For example, if iodine supply is normal, thyroid is on normal shape, so it will be cuboidal epithelium. If the iodine is not that much in your body, then the cells stretch like a flat epithelium. And if it has to do some hyperactivity like in Graves' disease, it increases in size. It shows that the thyroid is working very fast. Okay, so if you take a cut section, for example, this is one follicle, and you have taken a cut piece here, a bigger one. Now this is one cell, a follicular cell, and this is a lumen, this one, where this colloid is accumulating. Give your concentration here, right? This is the basic of the thyroid gland. Now what happened? This is nucleus, this is cytoplasm, and around the nucleus you have endoplasmic reticulum, you all know. And this thyroglobulin is been formed by endoplasmic reticulum, right? It forms and then they accumulate outside here as an exocytosis and comes here. Now it waits. For example, even the formation of this thyroglobulin is also related to TSH, thyroid stimulating hormone. And even after they come here, they need TSH to join this iodine with thyroglobulin. Now, where the iodine is coming from? It's coming from blood. So this is the blood vessels where we have iodine as an iodide state. It combines with sodium to form sodium iodide, right? So this sodium iodide through this symporter, sodium iodide symporter, they take this sodium iodide inside the follicular cell. This is one follicular cell, you know it. Now as it enters, it dissociate again, sodium and iodide. Now this iodide then travels and they are taken up into the lumen here through membrane, right? Still it is in an iodide state. Now here the oxidation takes place and now it is iodine. Clear? Now this iodine attached with this thyroglobulin, which has these points which it has to be attached. So this iodine through iodination attach here. If 4 molecules attach in one thyroglobulin, it will form thyroxine. If 3 atoms are attached, it will form triiodothyronine, right? You all know that triiodothyronine is more active than thyroxine. So what happens? Now the body needs thyroxine. You know, we have a feedback mechanism. When you have enough amount of thyroxine in your body, a feedback mechanism go to the hypothalamus and it stops secreting thyrotropin releasing hormone. Now you need thyroxine. So the feedback goes to the hypothalamus that we need thyroxine. Now this thyroxine, thyrotropin releasing factor will come out from the hypothalamus and it go to the pituitary gland. It stimulates anterior pituitary gland to secrete TSH, thyroid stimulating hormone, TSH. Now this TSH then comes down and then it goes to the thyroid gland and it stimulates. It attaches to the receptor and then it stimulates thyroid gland like this. Feedback here, we have less amount of T3 or less amount of T3, T4, hypothalamus, thyrotropin releasing hormone, It stimulates pituitary secrete TSH. It will join the TSH receptor and then it activates G protein, GTP converted GDP, cyclic AMP, and then the whole cascade of this thing starts. The machinery starts. How? More and more thyroglobulin is forming, more and more iodine is being taken up, more and more thyroxine is being formed, and it is taken out as an endocytosis to the blood. Now, as it comes into the blood, majority of the thyroxine and triiodothyronine are protein bound. Only a small amount is free, which is more active. Now, when the body needs thyroxine, it reaches to the particular cell which it has been needed. Again, this thyroxine dissociate into triiodothyronine at that particular place, because triiodothyronine is more active than thyroxine. Is it clear? Is it clear now how the body is functioning? Now what happens here? The thyroid hormone receptor, it goes there, attaches to the this T3 T4, which goes from the blood, reaches to the cell, attached to the receptor, and then it start doing its work. What does it do? As I said, most of them are protein bound. Only a small amount is free with this one. So what it does, it binds with the nuclear receptor, which I showed you here. Then it change the gene expression, increase carbohydrate and fat breakdown. Very important. So you are taking energy from carbohydrate and fat metabolism, and it is conserving protein by protein synthesis. So protein is being synthesized, and we are not using protein as an energy. We are taking energy from glycogen and fat. Clear? Okay. The result is increased basal metabolic rate. Now these, if it is normal, yes, basal metabolic rate is increased and you get your energy. But if it is hyper, so more and more basal metabolic rate, and the patient will feel warm, right? Sweating, hyperactive, palpitation. So these are all consequences of large amount of thyroxine or triiodothyronine. Is it clear now? Now coming to how it acts, as I said, it's, you know, all things. So we are there. If there is some disease, there are 3 areas from which you can have disorders. Number 1, if the thyroid gland itself is not good, we will call it primary. We call it primary. It's anything wrong with the thyroid. Anything wrong in the pituitary, means TSH extra secretion or less secretion, we call it secondary. And anything wrong with the hypothalamus, we call it tertiary. So primary, when the thyroid itself is being involved. Clear? We have different disorders: hyperthyroidism, hypothyroidism, non-neoplastic disease, and finally neoplasm. So we will discuss 3 of the entities today, and neoplasm on Thursday. You know that on Thursday we'll be having a single class at 1 o'clock combined here in the same area. Okay? Hyperthyroidism. As the name says, hyperthyroidism means thyroid is secreting little more. So we use the word either thyrotoxicosis, means hypermetabolic state with increased level of T3T4, or hyperthyroidism, one and the same thing, and it is interchangeable. Sometimes we use thyrotoxicosis, sometimes we use hyperthyroidism, but mostly we have seen that in Graves' disease, thyrotoxicosis word is mostly needed because it's a toxic one. and you know about grave disease, it involves female 10 times more than male. So if any female in a younger age, between 20 to 40, feels like hyperactive, sweating, palpitation, she must think that probably her thyroid hormone is deranged, maybe secreting more. It's a very, very challenging situation. You feel like something is going on in your body. So you just go to your endocrinologist, we will look for your T3, T4, and it happens with males also. It doesn't mean that only female get worried. Male can also be, right? Okay. Now, the disorders associated with thyrotoxicosis are these. I mean, diffuse toxic hyperplasia, which is grave disease, the most important one, grave disease, number one. Then we have hyperfunctioning toxic multinodular goiter. If somebody has a multinodular goiter, only one portion of the multinodular goiter become active, and it is started secreting more thyroxine. That is called hyperfunctioning toxic multinodular goiter. The third one is hyperfunctioning toxic adenoma. We have adenoma in the thyroid. 90% they are benign, means they doesn't secrete anything, but 10% they do, and that is a toxic one. Now I'll tell you what's the difference between these and grave disease. It's totally different. The sign and symptom of grave disease is different, although it is also hyperthyroid, and the sign and symptoms of these are also totally different. Now, there is two more. That is iodine induced, means somebody is taking iodine because it has some problem in the iodine, so extra iodine. So, but when the iodine level is more, she or he might develop hyperthyroidism and neonatal thyrotoxicosis associated with maternal. If the mother have Graves' disease, the child in the development situation, he might develop that, and after he is born, everything becomes normal. Then secondary, as you know, because of the pituitary, if you have extra secretion of TSH, it causes increase in thyroid. Now these are some of the disease which is not associated with hyperthyroidism, but you may have some. That is decurrence thyroiditis, which is also called granulomatous. This is painful one. Subacute lymphocytic thyroiditis, which is painless. Then struma ovari, which is ovarian teratoma with ectopic thyroid. The patient is coming like hyperthyroidism, female especially, and the doctors see her thyroid is absolutely normal. So you should keep this in mind that ovaries can have struma ovari, which is secreting ectopic thyroid hormone. Factitious thyrotoxicosis, which, for example, if somebody is taking exogenous thyroxine intake, instead of one tablet, if the patient is taking two, he may develop hyperthyroidism. This is how it looks like. Now this specifically, this picture is of grave disease, remember. Normally in hyperthyroid, you don't see this staring gauge as she is looking like this one. This you see only in grave disease. But usually, these symptoms are common. For example, a rapid pulse, tachycardia, palpitation, cardiomegaly, arrhythmias, and atrial fibrillation. Neuromuscular, you might have tremors, emotional liability, eye, staring gauge, and lid line. Skin will be warm and moist. Gastrointestinal, you have diarrhea, hypermotility, going bathroom again and again. Skeletal osteoporosis, and you have strong thyroid storm. Means suddenly you have a gush of thyroid hormone, and that is sometimes life-threatening. We have one of the professor here, and he passed away because of this position. I'm talking about 10 years ago. We were here together, and he had a thyroid storm. We took him to the hospital, and he could not survive. So it's so important, and don't take it lightly when somebody has hyperthyroidism. Now, how to calculate? We have a lab tests. So we do T4 and TSH. Now, if TSH is normal, T4 is normal, we call it as a euthyroid, means thyroid is absolutely normal, nothing is going on, right? If TSH is low and T4 is high, means it is primary hyperthyroidism. Why? Because TSH is secreting from pituitary. So pituitary doesn't want, because due to the feedback, TSH is not secreting, but still thyroid is producing T4, means there is a primary defect in the gland. It is started making his own without any information from pituitary. So this is primary hyperthyroidism. If suppose TSH is high, T4 is also high, means it is secondary, means pituitary is asking thyroid gland to secrete more and more thyroxine. Gland doesn't want, but as he has been ordered, he is making this thing. So it is because of the pituitary gland, so we are calling it as secondary. If TSH is high and T4 is low, this is called primary hypothyroidism. Although pituitary is asking thyroid gland to form more and more thyroid hormone, but it's not making it because there is some problem in the thyroid gland, means it's a primary hypothyroidism. Gland itself has a problem. Clear? If suppose TSH is low and T4 is also low, means it is secondary or tertiary hypothyroidism, means pituitary is not secreting TSH. Although thyroid gland is ready, but he is not getting signal to secrete thyroxine or triiodothyronine. Clear? Now the last situation is when TSH is normal, T4 is also normal. But here the TSH is low, but T4 is normal. Means it is subclinical hyperthyroidism. What does it mean? It means that pituitary is not secreting TSH, but T4 is being secreted by the thyroid gland in not that much optimal limit to call it hyperthyroidism, but it's still normal. But it shows that within few days, months, or year, probably it will convert into hyperthyroid. If TSH is high, means it has secrete more thyroid, but T4 is normal, means there is some problem in thyroid gland. Although it is asking to secrete more, but because it is normal, means it is trying to secrete, it is pushing to secrete thyroid hormone, but it is not up to the optimal limits. So when you check the T4 level, it will be normal, but it will be, the range will be in the lower limit. Means in a week or 2 months or year, the patient will develop hypothyroidism. Clear? Now let's come to the lead lag. In hyperthyroidism, if you ask the patient to see the finger like this and ask him to move without moving your head, ask to sit down. So if you see my eyes, my upper lid comes down with the eyeball. But in these patients, when they sit down, the upper lid remains up and only eyeball moves down. That is called lid lag. This is a typical sign of Graves' disease, right? Hypothyroidism, that was all about hypothyroidism. It is caused by structural and functional derangement in the which interfere with the production of thyroid hormone in the thyroid gland. The prevalence is only 0.3%. Subclinical, if you add subclinical hypothyroidism, then it becomes more than 4%. They are 10 times more in female than in male, and it has a result from defect anywhere from hypothalamus, pituitary, and thyroid. So you know all of it. Causes, primary cause is developmental defect like thyroid dysgenesis, PAX8 or FOXE1 or TSH receptor mutation problem. But this problem is after the birth. Thyroid hormone resistance syndrome, thyroid hormone is there, but wherever it's going for its action, the receptor is not responding. So it's a problem. Post ablation means because of the hyperthyroidism, the surgeon has taken out the thyroid gland, and now there is no thyroid gland, so no thyroxine. So you have to take tablets or radioactive thyroid iodine therapy, which kills the whole follicles. No extra thyroid gland, so you need to have that extra irradiation, can also damage the follicles. Autoimmune hypothyroidism, Hashimoto, which is your case. Iodine deficiency, the people who are living in those areas where there is iodine deficiency can cause hypothyroidism. Drug like lithium iodide, para-amino salicylic acid. Congenital one, from the birth they have defect, which is called biosynthetic defect, dyshormonogenic diameter. Secondary is pituitary failure, not forming TSH, or hypothalamic failure, which is almost rare. I have never seen it. Probably some of the clinician might have. This is how the patient look like. Now just remember the lady, staring age, thin, smart. At the age of 40, if the lady is smart and hyperactive, please always think of grave disease. On the other hand, you see very thick face, accumulation of glycosaminoglycan in the body. These patients are slow mind, respond less, myxedema, fat face, deepen voice because of the fluid accumulation. Cardiac is slow. In grave disease, it is fast palpitation. Here, slow. GIT, constipation. There it was diarrhea. Skin dry, cool, pale, cold intolerance. There it was moisten, sweating, hot, palpitation. Delay reflexes, myxedema, and ultimately they can go into coma. So there is accumulation of matrix substance, that is glucosaminoglycan and hyaluronic acid in the skin substance, and they cause non-pitting edema because of that substance is accumulating in the body. This is how it looks like. A lady having hypothyroidism, this is called myxedema, face, and after the treatment, this is actually the face. So after 6 months, if she comes like this, you will be surprised. I'm seeing you first time. She will say, no, I swear I have met you 6 months ago. So you see the difference, tremendous one. Cretinism. This is when the hypothyroid occur in the childhood. Cretinism. Why we call it cretin? Because it comes from the word Christ-like. Usually you see children, they don't sit in one place, turning here and there, doing some extra activity. But if they are sitting quiet, then they say, oh, it's Christ-like one. They are incapable of doing any sin. So they are commonly seen in those areas, mountainous area where there is iodine deficiency, like in Himalayas, China, Africa, and other mountainous areas. It has become much less frequent now because now majority of the food they contain iodine. Now this is how the child look like. You see, so it has impaired development, the skeletal system, and it has a severe mental retardation. So the mother is very important. They should see that their child is not that much active as compared to the neighbor child. The mother are really very curious. My sister's son is running like anything. My son is sitting quiet. So they are a bit jealous also regarding the child. Never say anything to the child of mother. But they have to be very careful, because if they are not very much active, they should go for thyroxine level, and if it is low, start giving thyroxine. They have a short stretcher, coarse facial features like this one, and protruding tongue and umbilical hernia. Now, if the maternal thyroid deficiency is before the development of fetal thyroid gland, then this mental retardation will be severe. You understand? And from the very beginning, as she become pregnant, she had a problem, then the child will be having severe. But if suppose hypothyroidism occurs after the development of the thyroid gland, so probably brain remains normal. You understand this point? Good. Now thyroiditis, we have means inflammation of the thyroid. We have 4 types: Hashimoto thyroiditis, decumbens thyroiditis, lymphocytic thyroiditis, and fibrosing or Riddle's thyroiditis. This you had a very good knowledge. Your case is of this one, right? Starting from Hashimoto. Actually, this was seen in worldwide area hypothyroidism where there is sufficient amount of iodine. It is seen in there was a scientist named Hashimoto. He was a pathologist. So he observed in 1912 that those patients who had this biopsy, they have a tremendous amount of intensive lymphocytic infiltration. So he has given initially the name of struma lymphomatosa, that 50% of the thyroid has been replaced by lymphocyte. So he has given this name struma lymphomatosa. Now it's commonest in US, and the male to female ratio is again 10:1. Female are more affected. Now in pathology, or you can see that there is a polymorphism. Sorry. It's a polymorphism of cytotoxic T cell associated antigen 4, protein tyrosine phosphatase 22, and a PTN22, and interleukin 2 receptor A chain, alpha chain. So there is a polymorphism of these proteins which can cause hypothyroidism. So if suppose in your family anybody has hypothyroidism, please kindly ask the other member to do polymorphism of these proteins. So if it is there and it is still they are normal, so please kindly observe them, or probably they will develop hypothyroidism in near future. So it's basically a breakdown in a self-tolerance to the thyroid autoantigen, right? So it's autoimmune disease basically. It is exemplified by the presence of circulating autoantibody against either thyroglobulin or thyroid peroxidase. I have shown you both of them, thyroglobulin and thyroid peroxidase, in the first slide, right? So this is basically an antigen attacking those two things. So what happened? Accompanied by progressive depletion of the thyroid, because of this, antibodies are coming there, right? Attacking T lymphocyte, and then they are destroying the thyrocyte and replacing by mononuclear infiltration and fibrosis. So more and more lymphocytes are coming there, and fibrosis taking place. Clear? Please kindly stop me if you are not understanding. I will repeat it for you. Stop me in the middle of my lecture. I will not mind. I only mind when you talk each other, honestly speaking. You say, sir, please kindly do it, repeat me. I am not able to understand. I will do it again. Clear? Pathogenesis. As you know, there are 3 important things which is going on here. One is the cell is directly attacked by CD8 cytotoxic T cells, which is killing the follicles, number 1. Number 2, we have T cell, and you remember my POD lecture? T cell, they secrete gamma interferon. right? This gamma interferon, they activate macrophages. In tuberculosis, the macrophage is converted into epithelioid cell. In tuberculosis, here they are just activating and they are killing the thyrocytes, means follicles. Binding to antibody, thyroid antibodies, that is anti-thyroglobulin or anti-peroxidase, and then antibody dependent cellular cytotoxicity. Now see this picture, it will be clear. So we have three different ways. Number one, CD8 cell directly killing the thyrocyte, right? CD4, Th1, they are a lymphocyte, they are secreting gamma interferon. This gamma interferon is activating this macrophage, and now this macrophage is attacking the thyrocytes. And the third one, antibody, which is against thyroglobulin and thyroid peroxidase, they go and attach to the thyroid follicle, and then natural killer cell, which is antibody dependent cellular cytotoxicity type 2 immunology, right? Hypersensitivity. They go and attach there and they kill the thyrocyte. 3. Clear? So these are the three important ways in which the thyroid has been destroyed. Now, these are the follicle, and then it is majority of the follicle has been converted or displaced by these lymphocytes. These are the follicle which are almost going to die. These are germinal center, the follicles, germinal center, another germinal center, and the follicle. So these follicle is been attacked, and the follicle, the thyroid follicle is been damaged, and then it is gone. Slowly and gradually, the whole thyroid gland will be replaced by these lymphocytes. Now, the important thing which you have to see here is these cells. These cells are called Hurdle cells. So, if you have lymphocyte and if you have Hurdle cells, they have a granular pink cytoplasm, then you call it as Hashimoto. If you don't see Hurdle cell, if you see only lymphocyte, then it's subacute lymphocytic thyroiditis. Clear? This is very important. You had to have Hurdle cells. If you see a smear, which I have given you in your PBL case, that PBL case has all Hurdle cells surrounded by lymphocyte. This is basically a diagnostic feature of Hashimoto. Clear? So if you see under microscope histology, you will see a granular pink cytoplasm, a larger cells like this one. These are all Hurdle cells. These are not Hurdle cells. These are normal looking follicle. But the cells inside here, these are all Hurdle cells, because this has been converted into this specific type. Now this is a picture, I don't know, probably I will replace it next year. They have a painless thyroid gland enlargement, some degree of hypothyroidism. So mostly they are female. Harsh means confused, and eczedema means a potato-like, which I have shown you in the last picture, right? So this is a typical of Hashimoto thyroiditis. Clear? Okay, now coming to subacute one. Subacute granulomatous one. Subacute granulomatous means you had to see granulomas here. It is also called decurvent thyroiditis, decurvence. Common between the age of 40 and 50. Again, male to female ratio is 4:1. Recent, they say that we have a respiratory infection a week ago or 10 days ago. It is self-limiting. If you don't treat it, after 2 months' time, everything becomes normal. Now, the pathology is basically is a viral infection, and the infection is, the patient will say that I have a upper respiratory infection a few days ago. Basically, Coxsackie virus, mumps, measles, and enterovirus are involved in that one. So what they do, the infection leads to exposure to the viral and thyroid antigen, which is released secondary to the virus-induced host tissue damage. Tissue damage, and the antigen is produced. As the antigen is produced, then the T cell comes up and they start attacking that one. This is the basic pathology here. Morphology, A gland is either unilateral or bilaterally enlarged. On cut section, it is usually firm and yellow-white, not shiny looking, cut surface as a normal one. So they don't have a more rubbery or normal looking brown texture now. So more of them are white or pale. Histologically, you will see in the initial phase neutrophils, which is forming a microabscesses initial phase, and later it will develop into aggregates of lymphocyte, macrophage, and plasma cells. And along with this, you see multinucleated giant cells. Okay, this giant cell will confirm that you are talking or dealing with granulomatous one, because granuloma you need a. In the later stage, then slowly and gradually only chronic inflammatory infiltrate remains and fibrosis, and this is how it looks like. If you don't treat it, it will remain, it will become okay after 2 months of time. So this is how it looks like. These are the multinucleated giant cells. This is thyroid follicle, which is almost gone. Another one is about to go. These are all lymphocyte. This is multinucleated giant cells, and the pale colored nuclei. This one. These are all macrophages. Why? Right? And probably you will see plasma cells also. What is the exact picture of plasma cell? It has a cartwheel appearance of the nucleus and eccentric nuclei in one side. Probably this one. Okay. Clinical course. Granulomatous thyroiditis. These have a severe pain in the thyroid. It's not painless one. Variable enlargement, and if you even don't treat, 2 to 3 weeks, it becomes okay. So nearly all patients have high level of T3, T4 initially and low T3 level, and after recovery, generally 6 to 8 weeks, the thyroid gland becomes normal. Coming to subacute lymphocytic, which is painless. That was a painful. This is painless thyroiditis. They are called as painless thyroiditis, and they cause little mild hyperthyroidism, because when lymphocyte comes in, when the thyroid follicle ruptures, it takes out T3, T4. So there is transient hyperthyroidism. In most of the cases seen in the adult woman mostly, and it is 5% of the patient, they are postpartum thyroiditis. After the delivery, they have such type of activity. So except for possible mild symmetric enlargement, the whole thyroid gland appears normal. So we can see lymphocytic infiltration, germinal center, and collapsed thyroid follicle. Here we don't see any Hurdle cell. This is the main diagnostic criteria. So we will not see any Hurdle cell and fibrosis, which has to be present in Hashimoto. So this is how it looks like. Again, full of lymphocyte, crushing or damaging the follicles, but these follicles, they don't have any Hurdle cell change. So we'll call it subacute lymphocytic thyroiditis. Clinical course, painless goiter, a mild hyperthyroidism, patient has transient hyperthyroid, or then it converts into hypothyroid, and by 1 year time, probably the patient become normal or euthyroid. But in some of the patient, up to 10 years of time, hypothyroidism may appear, right? Coming to the fibrosing riddles, now in the latest book, only 4 or 5 lines are given. They have taken out. But when we were students, there was a whole paragraph on it. So it's very less seen, riddle thyroiditis, rare disorder, and they have seen extensive fibrosis, and this fibrosis not remain in the thyroid gland, but it goes outside the thyroid, and it actually engulf the trachea also. It has a rock hard neck mass, and if you have that much rock hard neck thyroid, what you will think of? You will think of cancer, and that is why it is bit important that before making this diagnosis, please kindly take a biopsy, and then but it can also compress the trachea. This is how it looks like. Lymphocyte and the damaged follicle, extensive area of fibrosis. Now, we have ample amount of time, so I'm going well, I think. Grave disease, as I said, it is just opposite to Hashimoto thyroiditis because both of them has the same pathogenesis, almost. CTLA4, polymorphism of CTLA4, PTPN22 or the interleukin alpha 1. So there are three, the basic one. Grave disease, it's autoimmune disorder, that was also autoimmune, but it has a violent or long continued palpitation in female. Mostly female are affected. In Hashimoto thyroiditis, you don't feel any palpitation, although the female will be little fat looking, big face, as I showed you. But here, these ladies I have seen, they cannot sit in one place for more than 5 minutes. Sit down, and then no, sit down. When I was doing my MPhil in Pakistan, my class fellow, my colleague, she was little. And my professor used to ask me, Abraham, go and ask her that did she done his thyroid profile, because I think she had hyperthyroid. So, you know, these ladies are very active, and thin, lean, smart. It's better that you should go and check for that, okay? Okay, so there are tried for these one is the hyperthyroidism, which is due to the hyperfunctioning in large thyroid. Number 2, infiltrative ophthalmopathy. This is very important, which you only see in grave disease. You will not see this thing in any other one. This is a differentiating point. Hyperthyroidism and thyrotoxicosis, you can differentiate it like this. In grave disease, the eyeball is looking as coming out. These ladies, sometimes you feel little, afraid, why are they? She's staring you. She is not staring you. Her eyes are like this. But you feel, especially if they come with localized infiltration of dermopathy, which is called pre-tibial myxedema. So the skin under their accumulation of glucosaminoglycan, so you may have, but it's not common to everybody. I think only 25 to 30%. So what you have, anti-TSH receptor antibodies, which stimulate the thyroid growth, cause T4 release, and react with the retroorbital tissue, skin skin of the legs. The peak incidence is 20 to 40 years of age. Again, the female are 10 times more affected than male. The incidence is 1.5 to 2% in United States. They have seen concordance of monozygote in 30 to 40%, but less than 5% in dizygote individuals. And again, the same, CTLA4, PTPN22, interleukin 2 receptor, alpha receptor antigen, and HLA-DR3 alleles. So there is a polymorphism of all these. So if anybody has, please kindly check the other person of the family. If they have these, then they may develop grave disease later on. Pathogenesis, again the same, breakdown of the self-tolerance of the thyroid antigen, and then by this thyroid, there are 3 types of immunoglobulin which has been secreted. Now this pathogenesis is little different than Hashimoto. In Hashimoto we have CD8 cell, Th1 cell, and antibody dependent. That pathogenesis for Hashimoto. Here it is different. It is thyroid stimulating immunoglobulin which comes and attach to the receptor. Now when they attach the receptor, they think that TSH has joined and they start producing T3 to 4. The other one is thyroid growth stimulating immunoglobulin. Again, this immunoglobulin go and attach to the receptor, and by this attachment there is a growth stimulating immunoglobulin cause proliferation of the thyroid epithelium. Thyroid epithelium become more and more proliferation. So when initially they are cuboidal epithelium, now it becomes columnar epithelium, more wider, bigger in size. And finally, TSH binding inhibitor in immunoglobulin. Basically, they are stopping TSH to come and attach, but they are themselves attaching at the receptor, and the receptor feels that TSH has been attached, and they start making the thyroglobulin, thyroxine. Clear? So 3, thyroid stimulating immunoglobulin, thyroid growth stimulating immunoglobulin, and TSH binding inhibitory immunoglobulin. All of them, they are basically enhancing the proliferation of the gland. In eyes, what happened? There is marked infiltration of retroorbital space by mononuclear cells. Lymphocyte is accumulating. There is inflammatory edema and swelling of the ocular muscles. So the ocular muscle, all the 4 ocular muscles, they become swell because of this thing, inflammation. Accumulation of extracellular matrix like glucosaminoglykane such as hyaluronic acid and chondroitin sulfates behind the eyeball, plus increased number of adipocyte, means fat, on the back of the eye, and it is pushing the eye forward. So these patient has bulging eyes, as when you want to scare a child, you open your eye like this. But if a normal female has such an eyes, you will probably run away from that area. So these changes displace the eyeball forward. So it looks as probably it is coming out. So these features I am telling you, they are specific for grave disease. It will not be there in adenoma or multinodular goiter hyperactive one. It will not be there. So probably a question can be asked, how will you differentiate these two? So this is the main important feature in grave disease, which you will not find in the morphology. Typically, they have a diffuse hyperplastic or hyperplasia of the follicles. So there is this diffuse enlargement of the thyroid gland, not only one side. On cut section, they are meaty appearance, means normally they are shining brown in color. The shine is gone. Basically, the shine is due to colloid or thyroglobulin, right? But as the thyroglobulin has been utilized by thyroxine and triiodothyronine, it is empty now. So it looks like meaty appearance. Histologically, follicular epithelial cells, they are tall because now they are doing more and more work. Crowded. Sometimes they form a papillae, small papillae, but this papillae, they does not have a fibrovascular core. Papillary carcinoma has a well-formed fibrovascular core, and this is a differentiating point that you should not call this thing as a papillary carcinoma. Although the papillae looks like the same, but they don't have any fibrovascular core. So they have a lymphoid infiltration, mostly of T cell, and you find germinal center around it. This is how it looks like. It is diffusely enlarged thyroid, meaty appearance. Do you see any shining here? No shining, because it has been depleted. Now, if you see the histology, what is this? It is called scalloped. Very nice. Means it is eaten up. More and more thyroglobulin is being produced, and more of thyroxine is being produced, and the thyroglobulin is used in developing that one. Then you see this is a papillary projection, but you don't have any fibrovascular stock. Don't call it papillary carcinoma, which sometimes is misdiagnosed as papillary carcinoma. I have seen multiple cases. How do you see? The case come to you for revision. Please kindly have other opinion, and we see, oh no, it's not. The other pathologist said it's a papillary carcinoma. It is not papillary carcinoma, because papillary carcinoma, which we will be discussing on Thursday, it has a nuclear feature. If you don't have any nuclear feature, don't call it papillary carcinoma. We have a 4 or 5 definite nuclear feature to call it papillary carcinoma, along with the stock. So there is no stock here. Then we have lymphocytic infiltrate. We have some fibrosis around, which is not here somewhere. But the important thing is tall looking epithelial cells. which was cuboidal epithelium, now it is tall columnar. Okay, clear? Any question regarding this picture? Remember, please, whatever I am showing you the picture, please put it in your mind, because the same picture will come in your OSP exam. Now this is exophthalmos. The muscles or the eyeball is pushed from behind, and you know why? Inflammation, fat, glucosaminoglycan, and muscles. All of these four features pushing the eyeball. This is peripheral edema, mixed edema. It is also because of glucosaminoglycan. Now we are finished with grave disease. Now coming to the goiter, simple. There are two types: simple goiter or a diffuse goiter, multinucleated one. So what happened? It's the goiter is basically a big thyroid, and it's a Latin word, gutter, for the throat. So it is present in front, and this it's basically caused by defect in T4 synthesis, and a continuously TSH has been secreting, and the thyroid is not able to make T4. Why? Probably because of low amount of iodine, or because of some synthetic defect in the thyroid. So what happened? The thyroglobulin, because of the TSH, it is also stimulating follicle to secrete more and more thyroglobulin. Thyroglobulin is being produced, but it is not converting into thyroxine. So the thyroid gland is slowly and gradually increasing size. Now this is also a small goiter. She is a young lady. Every female, when crosses the menarche, has little bit enlargement of the thyroid, which is abnormal. And then after a year or two, it comes back to normal. So if you see, this is a smaller one, and probably it will go away. Usually either it's because of the iodine deficiency or some defect in sporadic one. So either there are some vegetables which are iatrogenic, or they can cause decrease in T4 levels. So either iodine or some vegetable or some enzymatic defect, T4 level comes down, TSH level comes up in these patients, and there is enlargement of the thyroid gland. And I have shown you it can grow up to this size. I have seen these patients. Usually our female, they shy of showing this thing to. If they could have shown in very early stage, probably they might not have developed this much of big thyroid. Okay, so these are the vegetables which can cause the goiter. This is cabbage, this is cauliflower, this is turnip, this is sweet potato. What is this? Peach. So this is not a vegetable, so I have just kept one, right? Okay, so this was all. Any question? Any question? You have understood the first slide, how the thyroxine is being formed. You want me to go back and show them? You are talking about Hashimoto?
No.
You are talking about grave disease. Okay. In the third one, what happens? The first one is TSH.
Yes, that makes sense.
Second one is growth. The third